Thank you, Peter. Thank you very much for the introduction. It's a great pleasure to be here today, and thanks to all those who are able to come along. I've got, I must admit, quite a few slides today, so I'll go at a bit of a pace, I think. But hopefully, if I do that, we will have some time at the end for some questions. So what I would like to cover today is really just a bit on the growing impact of dementia on our community and our health systems. I want to cover some of the major diseases that cause dementia, particularly some of the key features of those major diseases. Then on to, I guess, a little bit more at the cutting edge to look at what's coming in terms of potential therapeutic options, as well as advances in diagnosis. And then hopefully to wrap up with really where I think we need to be, which is a sort of a public health approach to dementia, particularly around a new area of relatively new area of interest, which is around reducing your risk of dementia. Now, dementia, as probably most people know on the webinar today, is actually not a specific disease in of itself. It's really a term that we use that covers a number of conditions and diseases. So really, it's a sort of a syndromatic classification. The thing, though, we always like to emphasize is that those diseases and conditions that lead to dementia is not just part of normal aging. So the things that you see in terms of changes inside the brain relate again to specific disease processes. And these have their reflection then in changes in brain function, particularly around cognitive function, often also behaviour, personality, and even motor function as well too. And I do say this is actually good news in a way, that these are actually diseases. They're not inevitable consequences of aging, because if we could understand these diseases to the extent that we should, then we should be able to come up with ways of intervening and in fact preventing or slowing down a disease process. So it's good that they're diseases that we can target them in the same way we might target cancer or heart disease or any number of other conditions. There are literally dozens and dozens of conditions that will lead to dementia. There are four, I guess, substantial ones, some of these of which I'm sure you've heard about. Certainly Alzheimer's disease is perhaps the one that's discussed the most. Then there's also frontotemporal dementia, Lewy body dementia, and vascular dementia. And pretty much these are all aging-related conditions. So it's not actually uncommon that people might have mixed pathology. So they might have combinations of, example, Alzheimer's disease and vascular pathology as well too. So they don't always occur sort of individually, if you like. So we also know there are a number of challenges that sit around dementia, again, in terms of its impacts very widely in our community. We know that diagnosis is not easy to obtain. It's usually a few years after clinical features are obvious that people are able to obtain a diagnosis. We do know that, again, historically, that there's actually, relative to other major conditions, there's low levels of knowledge really in the aged care workforce broadly, and health professionals as well too, and through to the community and family carers as well too. And that also has an impact on the next piece, which is really the quality of care. So we've been through a Royal Commission into the quality of aged care, which was not particularly flattering about the standard of care that people with dementia experience, particularly in residential aged care facilities, but also in terms of community care. And there are a lot of root causes for that, of course, but one of these might well relate to the extent of education and training that does go on in this sector. And I believe we've made advances in recent years in terms of being more inclusive of people with dementia in the community, but there still is also a substantial amount of stigma associated with dementia and really outright fear. So it's really often a condition that's not talked about very much out there in the community and shunned. And because of that too, I think that we have some negative impacts on the quality of care. But this, I think, is in a bit of a slow turn, and I think dementia now is being recognised as one of the most significant health, social, and economic issues of our century. I've just got up here a couple of examples of recent reports that describe the scenario that we're seeing at the global level, where basically there's probably around about 60 million or so people living with dementia currently, but that's going to increase substantially over the next few decades with the ageing of populations all throughout the world. And in fact, the fastest growth of dementia cases will be in low to middle income countries, which are seeing real gains in longevity, but along with that comes the big increase in these aging related conditions. The WHO's got motivated to again lead a public health response to dementia. Hopefully have a bit more time to talk about that at the end, but you can see that the estimated costs across the world were significant in 2015 and are going to keep rising with the numbers of people who are going to develop dementia. And this figure really tells the story of why we're seeing a big increase in the numbers of people with dementia. This is Australian data from the Australian Institute of Health and Welfare, and it looks at the prevalence of dementia at these various age groups down the bottom. And you can see actually when you're in your early 60s, relatively speaking, you've got a fairly low chance of having dementia. But as you get older, that chance of developing dementia actually rises quite dramatically. And you also see that even at the same age, women are much more risk of developing dementia than men. Overall, there's many more women who develop dementia currently simply because actually they just happen to live longer than men do. But even still, if you control for age, there's still disproportionately more women than men who develop dementia. And so with increased longevity, that just shows no sign at the moment in Australia of tapering off. We're going to see a big increase, particularly in the groups of people in our population who make it into their 80s. And then associated with that will be, again, a substantial growth in the numbers of people with dementia in Australia. So there's been a few estimates out there about how many Australians are living with dementia currently. We think it's somewhere north of 400,000 people. But then over the next few decades, this is going to basically double to somewhere again north of 800,000 people. If we look at individual coding of death, which is probably the best record in a way of determining how many people out there have had dementia, then in fact dementia is the second leading codable cause of death in 2022, with about 17,000 or so deaths, just marginally behind ischemic heart disease. And it's actually been predicted that probably 2023 is the year we'll see dementia becoming the single leading codable cause of death. It already is the leading cause of death of women, has been for some years. It's also, too, the largest cause of burden of disease in people over the age of 65, as well as, again, women more broadly. In terms of impacts on our health system, we know that if you end up in hospital and you happen to have dementia as well too, that you're in for a longer stay, around about, on average, 15 days in the hospital versus all other hospitalisations on average are about 2.7 days. So you can see that the impacts of dementia are felt quite broadly. And there's 1.5 million or so people who are estimated currently involved in the care of people living with dementia. So again, looking into the future, we can see that we're going to need a much bigger and better trained workforce to help cope really with the substantial growth in the numbers of people with dementia. And the costs, these costs are probably a bit of an underestimate in many ways, but the costs of caring for people with dementia are also set to increase dramatically. So the Wicking Centre was started about 15 or so years ago, really with a bit of a look into the future in mind in terms of the growing impact of dementia, across the spectrum, really. And we really started with a mission which was to try and make a difference in the lives of people living with dementia. And along with that came our intention also to do this, I guess, within sort of conventional university approaches, and to make sure that we were delivering education and doing research that was of high impact and hopefully making a difference. Broadly, most of the work that we do relates to three themes on dementia: the prevention, cause and care of dementia. And we're quite a multidisciplinary team. This is by intent, because we know that not one particular discipline has got all the answers. It's really by people coming from a broad range of backgrounds and deciding to work together towards research and education, as that's where we're going to probably get the biggest gain. And I'll talk very briefly too about our other educational programs, where again we're hoping that with a combination of different approaches to trying to boost the knowledge of dementia in the community, that hopefully we're making something of an impact on this area. But I want to turn now to talk about some of those major diseases that cause dementia. And again, I might well end up skipping over slides if I think that time's going to run out. But what I wanted to do, I guess, is give people an idea of what is the sort of the essential neurobiology or neuropathology of these conditions. And Alzheimer's disease is by far and away the one we know most about. It's probably responsible for 60%, maybe as much as 70% of cases of dementia in the community. It is, like many other diseases that cause dementia, progressive and degenerative. And what we mean by that is that you get worse over time. There is a staging to the pathology of this disease, and that is reflected in the symptomology that you'll see as well too. And it is degenerative. It involves the death of nerve cells and the loss of connections between nerve cells. And it's really that loss of connections over time that again underlies the symptomology. It's largely a disease though of the cerebral cortex. And so here's a couple of side views of a brain, an otherwise dead person, but otherwise healthy looking brain, and at the bottom somebody who had Alzheimer's disease. And you might see that this brain at the bottom looks a little bit withered, if you like. So there's been shrinkage of the brain, what we call atrophy as well too. And so it's really the nerve cells in the cerebral cortex and how they're connected up with each other that they start to die, at first slowly and then perhaps quickly over time. And again, that's when you start to see the emergence of these cognitive, behavioural and various physical symptoms. This is just a snapshot of some of these clinical features that you might see early to middle stages of Alzheimer's disease. Alzheimer's disease is also, it's like the other conditions that cause dementia. Sometimes it's very hard to tell when somebody started to develop this kind of condition. So we often refer to these as having an insidious onset. It can be a bit slippery to identify and diagnose very, very early in terms of clinical features. One of the cardinal aspects of Alzheimer's disease, though, again, reflecting how it damages the brain, is it does diminish your ability to form new memories. So that's then is also reflected in not being able to recall more recent memories. Sometimes, though, in some people, though, you can recall distant or long past memories much better than you can from the more recent past. But it has to be more than just memory. So if you've got some memory issues with aging, it's not necessarily Alzheimer's disease. It really does need to affect other areas of brain function. And just some examples here. So for example, organising yourself, what we call some of these sort of higher cognitive functions, losing your orientation in familiar space, or losing your orientation to normal circadian rhythms, problems in either understanding or producing language. Another one which can obviously be quite disabling and of a concern to carers is sometimes we see quite substantial personality changes. And then it's usually sitting underneath all of this is the person may well be in a state of confusion for much of the time. Now, back to being progressive, these features will just get worse really over time. And usually if somebody makes it to end-stage Alzheimer's disease, they're usually not very mobile, not moving around, prone and have very poor communication. But it is the one that we know most about in terms of research and neuropathological studies. And literally, this is the work of thousands of scientists across the world. And this is a bit of a simple summary, if you like. But we know basically that the main change that occurs inside the brains of people with Alzheimer's disease are aggregates of abnormal proteins. And these come in two types, these amyloid plaques, which you can see in brown here, and then within the nerve cells, something that looks almost like a tangled ball of wool, which we call a neurofibrillary tangle. So these are plaques that occur outside and around nerve cells, and then these tangles that occur inside the nerve cells. We know too, when you see these amyloid plaques, this is just a picture actually from a human brain. We know that where they occur, you start to lose these normal axons, which are shown in green, and then they're replaced by these abnormal processes, which we call dystrophic neurites. So there's lots of research that goes on to various aspects of this pathology. Many researchers focus mainly, for example, around looking at amyloid plaques and how they might develop. They seem to develop early on in the disease. Others who are interested in neurofibrillary tangles, because they may be more closely linked to the actual degeneration of nerve cells, which is the thing that again leads to the symptoms. But what's interesting, I suppose, about Alzheimer's disease is that these represent aggregates of normal brain proteins. So these are brain proteins that go wrong, if you like, and they become aggregated to form these pathological structures. Just an example, again, from some of the work we do on human brains here at the Wicking Centre. In blue, you can see a marker that we've used to label up some of these amyloid plaques, and in red is a marker for some nerve cells, and in green is a marker for some of those axons. And basically, where you see these big amyloid plaques occurring inside the brain, you'll see an absence of normal axons and indeed some sort of abnormal axonal structures as well too. So probably a little more detail than anybody needs at a bit after 1 o'clock on a Friday, but this is just to emphasise that when we look at these structures, these beta amyloid plaques as shown in red, against these are the nerve cells shown in green, that they represent abnormal proteins that you would find normally inside all of our brains. So normally these proteins or peptides are what we call soluble. They're floating around inside our brain. They're probably doing something useful. We're not sure what, but with this Alzheimer's disease process, they start to form these what we call abnormal fibrils, and they basically mass up into these amyloid plaques. And they're all derived, again, from a normal precursor protein called the amyloid precursor protein. There's still quite a lot of controversy out there about what's pathologically important, though, in terms of these brain changes. For example, this is just a little diagram showing that we think that the amyloid comes out of membranes of cells inside the brain, and there's one pathway that leads to them forming amyloid plaques, which we've seen, and then there's another pathway where people think that small aggregates of this amyloid may actually be the thing that's actually poisoning nerve cells. And there's lots of research really on both of those different pathways to try and figure out what's the most important pathological pathway. Here's just an example of some of the neurofibrillary tangle pathology that described earlier. Again, a nerve cell from a human brain shown in green, and all those little red bits inside that nerve cell are the beginnings of a neurofibrillary tangle. And these are very insoluble structures, fibrillar structures. They resist being degraded in all sorts of conditions. So in fact, once the nerve cell has died, they often leave a ring of these abnormal fibrils, which is sometimes referred to as a ghost or tombstone tangle as well too. So here's a nerve cell suffering, otherwise alive, with this abnormal protein called tau, which forms up that tangle. And that's when, after the nerve cell would die, it's gone and it's left that tombstone tangle behind. Again, sort of interesting feature of neurofibrillary tangles and their distribution in the brain is that they do have a predilection for certain parts of the cerebral cortex. So for example, in most cases of Alzheimer's disease, if you looked at primary motor and primary sensory cortices, and including visual cortices and so forth, there's actually very little neuropathology of this kind. It tends to occur in high amounts in those parts of the neocortex whose job it is basically to associate information. And so again, these nerve cells will die slowly over time, and you'll lose those connections, and the loss of the connectivity leads to those progressive clinical features. So we often talk about the staging of pathology in this condition, and these are just cross sections of brains at different stages. And so when you get up to stage 5, 6, and so forth, that's really when you're going to have substantial Alzheimer's disease symptomology. But we think that most people will go through some of these earlier stages where that tau pathology that's shown in brown in these cross sections, that starts in particularly in the temporal lobe, in a structure that's important for memory formation known as the hippocampus. And then it then spreads, if you like, through the rest of the neocortex, killing nerve cells and knocking off the connections between those nerve cells. We also know a lot too now about the genetics of Alzheimer's disease. So most cases of Alzheimer's disease don't have a strong, genetic flavour in terms of being linked to particular mutations, but less than 10% of cases probably are linked to a specific mutation in a particular gene, and we tend to refer to these as familial Alzheimer's disease cases. And these tend to also correspond to people who get dementia at a relatively early age, maybe in their 40s and 50s. Now, the genes that we know about that have these mutations seem to be all related to how we process that amyloid protein. So indeed, one of these is the amyloid precursor protein gene. Another one is called presenilin 1. Another one is called presenilin 2. And we know even with these genes, they encode for proteins and enzymes that are important for processing this amyloid precursor protein. So this is often used as an argument to say that the amyloid part of Alzheimer's disease might be particularly important in terms of being causing, I guess, at the end of the day, the sequence of neuronal changes that lead to dementia. For the rest of us, there are genetic risk factors. So these are just normal variations in genes that we find in all of the population. There's a whole suite of these now, but the major one that we've again had a lot of study around is called the apolipoprotein E gene. And essentially this comes in 3 flavors, and you get one of these from each of your parents. So there's an epsilon 2, epsilon 3, epsilon 4. So most people have 2 of the epsilon 3 genes, one from each parent. But the more epsilon 4s that you have, the greater risk you have of developing of dementia. But this is more like the dementia, the standard kind of Alzheimer's dementia that we see that comes on in the late 70s or so. So some unlucky people have 2 copies of this gene and a much higher risk of developing dementia. But even if you've got 1 copy of this gene, then your risk of developing dementia at any particular age is going to be higher than if you didn't have that gene. And of course, one of this raises, broad issues, ethical issues as well too, as to whether anybody would like to know whether you actually have these variations of this gene. People might have seen quite recently Chris Hemsworth of Thor fame basically went through a process of having his genes looked at, and it turned out that he did inherit one of these epsilon 4 versions of this gene, and this is had obviously had an impact on him and his thinking, I guess, around dementia risk mitigation as well. But broadly, this is a model that describes what we think happens, I guess, in terms of the changes in the brain that lead to dementia in Alzheimer's disease. That we think that there's a lengthy preclinical phase, maybe as much as 10, 15 or 20 years, where you start to see the build-up of those plaques inside the brain. They're followed in time by the formation of those tangles, beginnings of the loss of synapses. And then again, if you had a very sensitive neuropsychological testing, you would probably see that they had cognitive impairment. What really does tend to happen is it's usually after some sort of more functional loss, if you like, as well as the increase in symptoms. It's usually some time really after somebody has developed Alzheimer's disease that might get a diagnosis. And I think we always say to remember that at the end of the day, Alzheimer's disease is a terminal condition. It's a life-limiting condition. So it will end in if something else doesn't take you, it will end in death. But this is an idea, again, that we have a staging through a preclinical to a more clinical phase, and that becomes important when we think about diagnostics and treating this condition. So frontotemporal dementia, I'll just spend a little bit of time on that because this is one that's sort of an exciting area of research and one we're getting to know more about, again, through the activities of scientists across the world. So frontotemporal dementia is sort of the term that we use. More specifically, it probably should be called frontotemporal lobar degeneration. And there are actually a number of different diseases that can cause this condition, but they tend to have a sort of a remarkable effect on the brain in common that allows us to cluster them all together. And again, if we look in the side view of a brain of somebody with frontotemporal dementia, as the name would suggest, the area of the brain that's dramatically affected in these conditions tends to be the frontal lobes and the very anterior or forward parts of the temporal lobe as well too. And we see this pattern of knife edge atrophy, where you see substantial loss of nerve cells. By and large, frontotemporal dementia does correspond to what we often refer to as young onset dementia. People develop this condition in their 40s to 60s. Precisely how many people, what proportion of dementia cases are frontotemporal dementia is up for debate. Could be as much as 20%. Some people think it's a lot less than that. It can actually also overlap with other neurodegenerative conditions, particularly a motor neuron disease known as amyotrophic lateral sclerosis, or ALS. And its features are often, quite different to clinical features are often quite different to what we see in Alzheimer's disease. So it's often not so much memory issues that come to the fore. Could be behavioural personality changes. Again, sometimes these are quite diametric to what people were like before, and can be, again, quite troubling. People making poor decisions. There's often confusion in the clinical setting as to whether somebody's features like this relate to the neurodegenerative condition, or in fact might be more psychiatric. So sometimes they end up in hospital, multiple times while a diagnosis is worked out. But again, you can see some of these more, if you like, psychiatric features: repetitive and ritualistic behaviour, changes in diet, personal hygiene. Language is often an issue, as well as potentially troubling behaviour. There's often also a pattern of what we call pervasive apathy, where it's difficult to motivate people with frontotemporal dementia to undertake various activities. And unlike Alzheimer's disease, where we've got a pretty tight pathological picture, there's no one defining pathological inclusion, like a hallmark, like a plaque or a tangle. In some of these cases, we might have structures called PIC bodies. I'll just pick up on that as well in a moment. But basically, in terms of presentation, they think largely the initial presentation might relate to different, dimensions of what is probably more of a syndrome. And so the classification here tends to relate to what might be those initial symptoms, I suppose, that relate to that case. So we have these behavioural variant frontotemporal dementia, a language variant, and then various movement disorders, which went under other names previously, which we think also might be sort of clustered under this set of conditions. But similarly to Alzheimer's disease, there are abnormal protein changes inside the brain. And again, these largely involve otherwise normal proteins that seem to become pathologically altered. Interestingly, but it's not a standard picture though. So for some cases, what we might see is accumulations again of this protein called tau, and you can see those as these little balls in this picture here. Or there might be this other protein, which we refer to as TDP43, which again you can sort of see as these sort of more stringy looking structures, as well as these other labelled nuclei as well too. And there's a lot of interest in now trying to classify these cases of frontotemporal lobar degeneration based on the pathology, based on also those initial symptoms that are presenting, and also in terms of their genetics as well too. because more so than Alzheimer's disease, there's a much stronger genetic influence on frontotemporal dementia. And we think that about 40% of these cases you can actually probably track back to a genetic mistake, a genetic mutation. And some of these, just a list of different genes, you don't really need to know too much about them, but what's quite interesting that some of these actually are related to Alzheimer's disease. For in fact, one of these mutations sits on the set of mutations sit on the tau gene as well too. But there are other genes that are involved, and some of these seem to be more involved in driving particular variants. For example, that combination of frontotemporal dementia and motor neuron disease. Lewy body dementia is one that's receiving also more attention as well too. It can be clinically quite difficult sometimes to distinguish between this one and Alzheimer's disease. Probably again, 15% of cases are probably going to correspond, of dementia cases going to correspond to Lewy body dementia. And its main pathological feature is a structure called the Lewy body, which is a sort of a spherical structure that you find inside nerve cells. And that's also made up of, we know it's made up of probably lots of proteins, but the major one is called alpha-synuclein. Again, a normal protein that in all of our brains is doing something sensible and normal, but with this disease process becomes aggregated and accumulates inside the nerve cell. Also, in many of these cases, you will also find beta amyloid plaque. So we're not convinced necessarily that Lewy body dementia is a pathologically distinct condition from Alzheimer's disease, that they may well be related. And it does have some interesting clinical features, particularly visual hallucinations. So people with Lewy body dementia often describe very well constructed visual hallucinations that often aren't particularly troubling to them. They may note the existence of people and animals and things that nobody else can see. But that is, again, I guess, a consequence of the degeneration of the brain. And for many people with Lewy body dementia, they will have some degree of Parkinsonism. And so, again, pathologically, this is quite interesting because if anybody on the webinar knows something about Parkinson's disease, and we know that also in Parkinson's disease you see Lewy bodies, not so much initially in the neocortex, but more in the brainstem. And so there's actually a view out there that, in fact, what we might be talking about is some sort of syndrome, that if you start to develop Lewy bodies initially in your neocortex and they spread to other parts of the brain, then you might develop Lewy body dementia with Parkinsonian features. Or for people with Parkinson's disease, it starts in the brainstem. They'll have the motor features of Parkinson's disease, and as those Lewy bodies spread to the cortex, they may well also then develop dementia, so Parkinson's disease with dementia as well too. So this is a really interesting area of research. Vascular dementia is sort of a complex area. There's been lots of different names for vascular dementia over the years, and they're probably not all exactly the same condition, but ultimately what happens with vascular dementia is an interruption of the normal blood supply to the brain. Brain is greedy for blood and oxygen. If you start to see a pattern of pathology affecting the vascular system, particularly over time, then parts of your brain will start to die off. And more typically, I suppose, for most cases of vascular dementia, the site of that disease is in really the small blood vessels that you might find in the white matter that sits underneath the grey matter in the cortex. Some of these cases have what we call conjunctival amyloid angiopathy, and that's a picture of an example here. This is when an amyloid-like protein actually binds to blood vessels inside the brain and cause damage to the blood vessels. So whether it's due to the cumulative effect of this condition on those small blood vessels in the white matter, or in some cases it might be due to a sequence of more significant stroke-like events as well too, that over time you'll see a pattern of degeneration that we sometimes refer to as a stepwise pattern of degeneration. So where people might deteriorate, be stable for a period of time, and then deteriorate again. And some of these are some of the clinical features that you might see associated with vascular dementia. Again, some of them more at the affective or psychiatric side, also including some of those higher executive functions and problems really around gait and movement as well too. just to touch on very briefly, just because it's in some ways something we've known about for some time, but it's I guess consideration out there in the community has risen quite dramatically in recent times, is childhood dementia. Now, not a particularly, fortunately, not a particularly common form of dementia. So the prevalence is about a bit over 2,000 or so children in Australia with this condition. But you can see even at those numbers that they're quite similar to some other conditions that we actually hear a lot about and see a lot about in the press, particularly around motor neuron disease. By and large, these are genetic conditions, so you can track them down to genetic mistakes, genetic mutations, and there's more than 70 different distinct genetic conditions, and they affect basically the cell biology of nerve cells in different ways, and sometimes in overlapping ways as well too. But it is I guess a particularly awful condition, being largely fatal. They're incurable. There are some symptomatic treatments that are available for particular clinical features, but it's also a condition that we need to definitely raise the awareness of and increase the services that are available for childhood dementia and for those families in the community. Now, turning to looking at what's happening in diagnosis and treatment, and I can see I'm always starting to run out of time, so we'll see how this goes. But basically, there are a lot of really interesting new ways of approaching diagnosis that are emerging. There's a lot of interest in what we call brain imaging. So this is using MRI, for example, or other live imaging techniques where we can actually visualize the tau or the amyloid plaque inside the brains of people and evaluate whether that might be having an impact on their function. Another really interesting area is looking at what we call fluid biomarkers. So this is taking a sample of cerebral spinal fluid or blood, analyzing it in a very sensitive instruments to see if we can measure some of those proteins that I mentioned that were linked to those various conditions. Another really interesting area is around digital biomarkers. So can we use AI and what we sometimes refer to as computer vision and use this to analyze very subtle changes in for example, motor abilities to try and determine whether somebody might be in an early stage of a neurodegenerative condition. There's also a lot of interest throughout Australia now on trying to refocus around what is the appropriate setting to obtain a diagnosis for dementia. So again, some good work around primary health and supporting GPs to help make those diagnoses, and also interest in what we might do in terms of specialty cognitive clinics, what we used to refer to as memory clinics, and how can we sort of improve on these models so that people can get the access that they might need. In terms of biomarkers, I think the blood-based biomarkers is really one of the most fascinating and potentially, change-making discoveries that have occurred in recent years. And there's an idea out there that, in fact, perhaps by looking at some of these biomarkers, again, maybe from blood or maybe CSF or from imaging, we might be able to classify people in terms of their pathology. Have they got amyloid? Have they got tau? Have they got evidence of neurodegeneration? We sometimes refer to this as an ATN classification. Just very quickly, this is how this might work then, is if you're actually cognitively unimpaired, but you've got evidence of these pathological changes, then that would help identify whether you might actually be in a preclinical Alzheimer's disease phase. Conversely, if you don't have some of these markers, it may well be that you don't have Alzheimer's disease, but you might have another condition that would lead to dementia. Just an example of some of the biomarkers that people are chasing down, and one of the really interesting ones is the tau protein that I mentioned is linked with tangle pathology. You can actually measure very small amounts of this in the blood of people at higher levels when they have Alzheimer's disease, and there's even some evidence that this may well increase some years before you might have obvious clinical symptoms. I'll skip over that one. In terms of therapeutic strategies, we don't have really many good options currently for any of the conditions that cause dementia. What we have is drugs that will potentially provide symptomatic relief. And this is an example of what's been approved. Aricept is probably the most popular drug of these classes. And what they tend to do is provide benefit to some people for a short period of time, which I guess, you know, is actually useful, but doesn't really do anything about modifying the underlying disease process. And if we think into the future, what our therapeutic goals are, curing a condition like Alzheimer's disease is not likely to be possible. Once you've got established Alzheimer's disease, the nerve cells are dead, the connections have gone, and unless you can restructure those connections in some way, you won't be bringing somebody back from that condition. So symptom management still is important, but this is really where the game is now, is trying to modify the disease process, or indeed trying to protect the nerve cells from those pathological changes inside the brain. And we're also moving away now really from looking at these drugs and testing them on people with established clinical disease, because again, it's probably too late. And where the action really is now trying to identify people, maybe using those biomarkers at a very early stage of the disease to see if they can modify the disease course and effectively prevent people from developing dementia. And just a very busy slide just to give you an idea of the numbers of drugs that were in the drug development pipeline for dementia back in 2020. So lots in phase 1 or phase 2 and phase 3 development. And you can see what their sort of target of attack may well be as well too. There's unfortunately a very high failure rate really in terms of drug trials for Alzheimer's disease, but there are some glimmers of hope. And one of the glimmers relates to what we call immunotherapy. So this is an idea of mobilizing our immune systems basically to attack that pathology that occurs inside the brain. Now, there's two types of immunotherapy, what we call active immunization, which turns out to be a bit too dangerous, and people have withdrawn really from using that. This is when we might use beta amyloid or tau to basically be an antigen and stimulate an immune response. That's not, it tends to be harmful. So the approach now is what we use is actually at the other end, we use engineered antibodies to these proteins. So they'll be engineered in a lab and delivered and directly. And the idea is that they get in and bind to those abnormal proteins and mobilize their removal from the brain. And now there are a lot of these antibody drugs out there. We sometimes refer to them as MABs, particularly to beta amyloid. The one that's got a lot of attention more recently is called lecanemab. And this is just, the results of this was just published this year. And lecanemab and aducanumab have also been approved in the US for use. Now, this just shows basically how people progressed on this drug versus placebo. This is just a measure of cognitive change over time. And what we basically can see is that, in fact, both groups got worse. But if you're on the placebo, you got a bit more worse. You got more worse. That's the correct English than if you were on lecanemab. But the actual amount of difference at the end of the trial wasn't particularly substantial. But it has been approved. The problem with some of these kinds of drugs, though, is that they can be associated with quite significant side effects, particularly swelling of the brain and perhaps also hemorrhage as well, too. So there was a high rate of these abnormal side effects. So it's going to be expensive. It's up for approval at the moment by the TGA. You're probably not going to be able to get this through your GP. You're probably going to have to go through specialised centres, because basically there'll be criteria to qualify to be able to use this drug, and then you'll have to be monitored with frequent imaging in terms of making sure that you don't have too many negative side effects. Look, I want to leave some time for questions, so I might even end on this slide. I think that this is really a new area that is very exciting, which is really around dementia risk modification. So most of your risk of dementia sits with aging. The older you are, the higher the risk you have. Then some of those genetic factors also play a part. But it's been estimated that if we could actually eliminate all of this set of 12 risk factors in the population, we would have 40% less dementia occurring. So that gives, I guess, a reasonable target for us to think about the potential for mobilising, I guess, the population to and our society to do something about reducing the risk of our populations. And what we know is that some of these things are important at different stages of life. For example, the more education you have earlier in your life, the less chance you have of developing dementia. Hearing loss in midlife seems to play an important role in dementia risk. Then things such as social isolation, physical inactivity, air pollution, smoking, they seem to be more important and having their effects in later life. It's really important, though, to recognise that while to some degree, obviously, we can take control of some of these factors in our life, it's not always easy. And many of these risk factors have their determinants in our social and economic settings. So potentially, as well as asking people to potentially attend to their own risk factors, there may well be levers at the policy level that we need to think about in terms of modifying the risk of the population. So bear with me as I just skip through some slides, just to remind people too that I guess one of our approaches in terms of a public health kind of response to dementia is that we offer basically an ecosystem of educational programs that hopefully are tailored to provide dementia education and also some education around aged care at the right level, at the right time, depending on somebody's particular needs. And we're really happy that we've got a dementia specialisation within this postgraduate program related to advanced practice. People probably best know us for our one of our educational programs called Massive Open Online Courses, or MOOCs, and we've been doing this for about 10 years or so, and we've tried to do a lot of research around them. We've had over 600,000 or so enrolments into these MOOCs, close to 400,000 or so in Australia. And one of these MOOCs is really about building capacity to understand dementia more broadly and holistically. And then the other one really has a focus on informing dementia risk mitigation. And we'll just finish with this slide, which is, I think, where we need to be into the future. I think the WHO is quite prescient in this regard. We know there's a National Dementia Action Plan coming for our Commonwealth and state governments in the following year. And these are the sorts of areas that we really need to think about if we're going to, again, tackle all of the issues that relate to the impact of dementia on our, again, the social health and economic sectors. So we need to be more dementia inclusive. We need to look systematically at dementia risk reduction, providing people with access to diagnosis and the right levels of care, supporting the carers themselves. And of course, research and innovation remain very important. There's just some quick acknowledgements of all the people who actually did all the work and the people who have funded us. So with that, I might finish there, Peter, and hopefully there's time for a couple of questions.